So good afternoon, everyone. Thank you so much for joining us for this important webinar, Homefront Wellness, Veteran Mental Health and Suicide Prevention. We are offering this program in honor of the Veterans Day holiday coming up to address an important issue affecting a important population of our community and of our society. So I will allow our speaker, Demetria Chilton, to introduce herself in just a moment. But before we begin, I wanted to say a few words about NAMI Greater Cleveland and also speak about just a bits of the housekeeping notes for participating in today's webinar. And this webinar is being recorded. It will be made available on the NAMI Greater Cleveland YouTube channel later this week. The slides will also be made available to you after this presentation. All we ask is that you complete a short anonymous evaluation for us at the end. Please remain muted throughout the presentation, and please definitely use the chat feature if you have any questions about the content in today's webinar. So a few words about NAMI Greater Cleveland. Many of you may be familiar with NAMI, some of you may be newer to our programs. NAMI is the National Alliance on Mental Illness. It was founded in 1979 in Wisconsin by a group of mothers of children with mental illness. And it was formed as a grassroots coalition around their kitchen tables because they wanted to create a movement that would support understanding and acknowledgement and education in one's local community around the reality of living with mental illness in one's family. NAMI Greater Cleveland is a local affiliate of NAMI. We serve Cuyahoga County. Our mission is dedicated to improving quality of life for individuals with mental illness and their families. And we do that by providing education, support, information, referral, and advocacy. We offer support groups for people with mental illness, support groups for families. We offer educational programs. We do extensive education and outreach to the community around mental health, including with law enforcement, college students, schools, healthcare professionals, corporate groups. And we also have a helpline that is available Monday through Friday, 9 to 5. You can call that number if you have questions about accessing treatment, referral to resources in the community that may be beneficial for one's well-being and recovery. NAMI also supports advocacy in the sense of raising awareness about mental health, reducing the stigma around mental illness, and overall contributing to a movement in which it's socially and emotionally okay to talk openly about mental health. That's a bit about NAMI. Happy to answer questions anyone may have about NAMI at the end of this presentation. But without further ado, I'm going to hand it off to Demetria to introduce herself and to begin sharing our presentation. So thank you for joining us.
Thank you, Matt. Good afternoon, everyone. My name is Demetria Chilton. I am a social worker at the Cleveland VA located at Way Park. I work on our suicide prevention team. I'm a suicide prevention coordinator, and essentially what I do is work with veterans who have been identified as being high risk for suicide. And that could be for a number of reasons. It could be that they've had increased suicidal ideation and have possibly identified a plan. It could be that they've engaged in some behaviors related to suicide, or that they require some kind of mental health treatment or inpatient treatment because of suicidal behaviors. And so we identify those veterans as high risk, and we try to wrap them with some enhanced services just to make sure that we are reducing their risk and make sure that they are linked with the services that they need, because obviously our ultimate goal is because we want them to remain alive. So that is what I do for the VA. So I'm going to talk a little bit today. Matt, you can move to the next slide for me. Thanks. So what I want to kind of focus today on kind of identifying some mental health conditions within the veteran population. Of course, there are some obvious ones, but I want to touch upon a couple others. I want to discuss suicide risk within the veteran population and talk about some stigmas related to accessing mental health treatment, because a lot of our veterans, don't reach out for treatment when they need it. And there is a lot of stigma related to that. And I kind of just want to touch on those and how we can manage those stigmas. And also touch a little bit about the public health model, because suicide prevention is not just, something that's centralized within the VA. We want to talk to the greater population about what we can do to reduce the risk of suicide. Next slide. So mental illness in the veteran population. So, one of the most publicized mental health challenges facing the military population is obviously PTSD and depression. Those are some of the more common ones that we hear about. And research has suggested that approximately between 14 and 16% of US service members who have been deployed to Afghanistan or Iraq have PTSD or depression. And that's pretty significant. So again, I know that those are the ones that we most commonly hear about. We hear about PTSD, we hear about depression, but sometimes we don't necessarily know exactly what that means, what symptoms that involves, but those are typically the higher ones that we see. Next slide. So again, although these mental health concerns are highlighted, there are other issues like suicide, traumatic brain injury or TBI, substance use, interpersonal violence. All of these things can be equally harmful to the population, to the US service members population. And so we kind of want to, again, touch on those as well. These effects can be they can be wide-reaching and they can have substantial impacts on service members and their families. Mental illness, it often has like a ripple effect on families. So, it can create tension, it can cause uncertainty, significant changes in how we function in our everyday lives, certainly adds an amount of increased stress. And it impacts the way how we do our day-to-day functioning. And so different family members are obviously impacted in different ways. And so we just kind of want to highlight some of those ways and touch upon that and see what we can do to help not only the veterans, but also the families. Next slide. So while combat and deployment is linked to increased risk for mental health conditions, which means generally military services, it can lead to difficulties, but there's no specified timeline for the presentation of these mental health concerns. So it's not automatic that if you're deployed that you're automatically going to suffer from PTSD or you're automatically going to see these symptoms once a veteran returns home. So times are particularly stressful for individuals and their family who are serving near a combat zone or when they're separating from the active military. So again, it doesn't mean that like right when a veteran comes home that you're automatically going to be wondering, do they have PTSD? Are they going to have nightmares? Are they going to have some kind of symptoms? We don't know. And it may not manifest until weeks later. It may not manifest until months later. And oftentimes it may not manifest until years later. We currently work with a veteran population who are just now starting to touch on PTSD symptoms related to when they were in the Vietnam War. And we know that that was over 40 years ago. So it's not kind of it's not something that's going to happen right away. Sometimes it does, but oftentimes it doesn't. And so, when you're dealing with veterans who are suffering from mental illness or suffering from PTSD, depression, it's kind of normal to feel like a wide range of emotions. Sometimes we don't know what to do. We might experience fear, like how are they going to behave when they come home? Are they going to be violent? Are there certain things I should say or certain things I shouldn't say? You might start to feel some guilt because, obviously our service members have served our country and we don't know how to respond to that. Sometimes we don't know what to do. You may experience some sadness, obviously, because you're dealing with something that you don't know much about. You don't know how to help them. And then sometimes you may be angry. You may not know how to deal with this. And because it sometimes people suffering from mental illness can be combative, that kind of puts us on the defense and makes us equally combative. So all of these things, I kind of want to stress are things that are normal. It doesn't make something wrong with you. It doesn't mean that you're doing something wrong. It just means that this is normal. And it's kind of important to acknowledge that, in order to be able to work through it yourself and then to be able to help our veterans work through it. Next slide. So post-traumatic stress was initially introduced in around about 1980. And of course, it was driven in part by the after effects of the Vietnam War. So PTSD is often researched in war and disaster survivors, but it also can affect anybody, including children. Usually seen in survivors of violent events such as assault, disasters, terror attacks, and war. But it's also possible to experience PTSD through secondhand exposure. So that means if you were exposed to somebody who has experienced some of these things, That could also be, you could also have PTSD from that as well. So next slide, Matt, sorry. Many individuals exposed to trauma have transient numbness or heightened emotions, nightmares, anxiety, hypervigilance, but usually they'll kind of overcome these symptoms within 1 month. But in about 10 to 20% of cases, symptoms usually become more persistent and they can become more debilitating. And those are the ones that we are giving that diagnosis of PTSD. So, it features kind of having those intrusive thoughts, those flashbacks, nightmares regarding the trauma, or avoiding certain situations, avoiding certain places because they remind them of the trauma, hypervigilance, and also having trouble sleeping. I talked to a lot of veterans who suffer from PTSD who cannot go to sleep or are often afraid to go to sleep because they're concerned that they're going to have these nightmares and they're going to keep reliving that event. And so oftentimes their sleep is a major issue. Reliving the event can feel as threatening as the inciting event. So even though they're no longer in that situation, they're constantly reliving it over and over again and feeling like they're right back in that particular situation. So as we know, the symptoms can interfere with our interpersonal and our occupational function. Spouses, I talk to a lot of spouses or a lot of significant others who say, that this has impacted them significantly because they don't know what to do. It's impacting their day-to-day relationships, and it's impacting the veteran in their day-to-day lives, whether it be work, whether it be they're going to school, any kind of day-to-day functioning, it has a significant impact on them. Next slide. So this is just a little bit of data. The number of veterans suffering from PTSD during the service area of OIF, which is Operations Iraqi Freedom, or OEF, which is Operation Enduring Freedom, is roughly about 11 to 20% in a given year. So that means about 20% of veterans who were in the war, in the Afghanistan and Iraqi war, are diagnosed with PTSD. We see about 12% from the Gulf War and Desert Storm, and then about approximately 30%, which we know is significantly higher from the Vietnam War. Next slide. So depression is also, it remains one of the leading mental health conditions amongst veterans. Close my window, I'm sorry. You're breaking leaves outside. Hold on 1 second. Okay, sorry about that. So depression remains one of the leading conditions among veterans. In part that's due to because they've been separated from their loved ones, they're separated from whoever their support system is, the stressor of being in the military, the stressor of being involved in combat or the potential to be involved in combat. And then, being in active duty and being just part of the veteran population. And oftentimes, veterans were already diagnosed with depression or had some depressive symptoms prior to entering the military. I often hear that a lot of times some of our vets entered the military to get away from trauma or with the hopes of getting away from trauma or kind of escaping some things that were going on within their families. But then they're kind of exposed to that or those symptoms become more exacerbated, once they sign up for the military. So some major depression manifests through many symptoms, including having a depressed mood, loss of interest in activities, isolation, insomnia, again, those issues with sleep, weight loss or weight gain, psychomotor retardation, which means they're just not moving as like they should, they just kind of have that lack of motivation, decreased ability to concentrate, feeling worthless and having thoughts of suicide. Next slide. So veteran rates are at the highest level right now in recorded history, with the annual deaths of suicide being about 6,000 veterans per year. It's actually a little over 6,000. And so it has ebbed and flowed probably since about 2001, but it is still at a very, very high level of about, like I said, roughly a little over 6,000 veterans per year who are committing suicide. Next slide, thanks. So suicide among veterans and non-veterans. Some of the key findings is that, again, about 6,146 veterans of suicide in 2020. So that was an average of about 16.8 per day. In 2020, there were about 343 veteran suicides, more than in 2019, fewer, I'm sorry, than in 2019. And the number of suicides was lower than each prior year since 2006. So it is a little bit lower than what it had been historically about 10 to 20 years ago, but still a very, very high number compared to non-veteran adults. So in 2020, adjusting for population, age, and sex, the suicide rate for veterans was about 58% greater than non-veterans. And of course, firearms were the method of suicide in about 74% of male veteran suicide deaths and about 50% of suicide deaths among women, which is significantly higher. So we are seeing that because firearms are easily accessible, because most likely a lot of veterans still have access to firearms, they know how to work firearms, and that's their right to be able to have them. And so we tried a safety plan, we tried to see if they'd be willing to take the guns out of the home or come up with other methods, but it is a large population of veterans who do have immediate access to firearms. And so that is the most common cause of suicide deaths. Next slide. So the average number of veteran suicides per day went up from 2001 to 2020 to from about 16.4 to 16.8. And I know that doesn't sound significant, but it is. And again, it was the highest in 2018, which was about 18.6 per day. And of those who completed suicide, approximately 40% were among veterans who were involved in mental health care, and about 60% were among other veterans. So what that means is, about 40% of those veterans had some involvement, whether it's mental health or some kind of involvement with the VA system, and 60% did not. Next slide. So among those who died from suicide in 2020, the prevalence of depression was the highest, was the most prevalent, which was about 35%. And then of course, PTSD was a little further behind at about 26%, but not too far, about the same numbers. And then there were other disorders. Alcohol played a part in it in about 25% of the population. Cannabis use was at about 20% as well. About 8% as well, and bipolar disorder, opioid use, and personality disorders and schizophrenia. Those were some of the other ones. But again, the most common is depression and PTSD. Also in 2020, the unadjusted rate by sex, men were at about 32% higher of an increased rate of 32% more men completed suicide than women. Men were about 32% and women were about 14%, like per 100,000 people. In 2001, if we based it on when we looked at sex and when we looked at age, some of the higher rates was between the population of ages 18 to 34. In 2001, veterans between the ages of 35 and 54 had the highest rate, but now we're seeing more recently that between the ages of 18 and 34, the rate is more higher. Suicide rates among both male and females increased from 2019 to 2020, but all other groups pretty much decreased or stayed about the same. And this is a look at suicide rates by ethnicity and race. White males are significantly higher for suicide at about 34%. And African-American are at a little bit lower rate at about 14.2%. So almost half. That is the significant difference. So you've got about 30% in the Asian, Native Hawaiian, or Pacific Islander population, and about 30% of American Indians or Native veteran or Alaska Native veterans, and again, about 14.2% among African Americans. So essentially, white veterans were more than twice the rate of African American veterans to complete suicide. We also looked at the LGBTQ population and the suicide rates among veterans with LGBT and related identities. And what we found was LGBT people are more likely than their cisgender and heterosexual peers to experience suicidal ideation and behavior. They're also more likely to die by suicide, but their mortality data for the LG population is limited. And in part, that's because of specific, just kind of trying to classify how the LGBT population identifies. And so we're trying to gather more information about that, but we don't have as much information as we could right now. The victimization and stigma and decreased social support were found to be the most relevant suicide risk factors among the LGBT veterans. Because they're still going through the, even though there's no longer the don't ask, don't tell policy in the military, but it is very much that the LGBT population does not always feel comfortable coming out, discussing their sexual identity. And so they get stigmatized about that. There is still a large population that are being victimized by that. And so we are seeing more higher rates of suicide among the LGBT population. Sexual minority veterans are twice as likely as sexual minority non-veterans in the general population to own firearms, which again is a significant independent risk factor for suicide. And what we see across all populations is firearms is still the most common method. Understanding the cultural context of suicide in the United States. So what we kind of want to stress is there is no all-encompassing explanation for suicide. What the numbers tell us, just kind of the broad summary data, is that, there's no single path or takeaway from suicide. No one in particular is to blame for suicide. And there's no single medical cause, etiology, or treatment of suicide or prevention strategy. We want to make sure that we're including everybody, not just veterans or not just family of veterans. We want to include everybody in the community when we're talking about suicide and how we can prevent it. Next slide. So instead, what we want to stress is that suicide involves dynamic and individual interactions between the following domains. International, which could be war or the global economy. National, which could pertain to economic disparities, media portrayals and accounts, policies pertaining to lethal means access, and policies pertaining to healthcare access. We want to stress the importance of the community and how it impacts suicide and how it can help to prevent suicide. So that could be healthcare access. We want to make sure that our veterans have access to healthcare, whether that's through the VA. I mean, obviously, we would love for them to have their healthcare at the VA. And typically it's at no cost to them, or it's at a very low cost. But when it comes to mental health, everybody has access to mental health at the VA. So we want to make sure that we are stressing the importance of that access and making sure that they know that they.
You are welcome to go ahead where you stopped.
Okay. Okay. So I was just talking about suicide and suicide being complex. Again, it's not one all-encompassing thing. There's no one reason that veterans, or anyone for that matter, commit suicide. It is usually a number of different factors. And so to prevent veteran suicide, we need to maximize those protective factors and minimize those potential risk factors. And that's got to be at the individual, the interpersonal, and the community and societal levels as a whole. So risk factors are those things that are associated with increased likelihood of suicidal behaviors. Yes.
I'm sorry to interrupt. You're not sharing your screen and we cannot see you. So whichever you want to be doing is not currently happening.
Hold on one second. Let me pause and pull up my slides. Hold on one second. Can you see my screen?
I'm back. I'm back.
Oh,
I'm sorry, my computer crashed.
okay. Are you sharing or?
I'm sharing.
Okay. Take mine down.
I think we were right here.
We are on suicide is complex. Next one.
Okay. Just a second.
Okay, right there.
Hold on. Come on.
Can you see it?
I'm trying to go to the start slideshow section.
Okay.
Sorry. Okay, here we are.
Okay, perfect. Thank you. So again, like I was saying, suicide is complex, and to prevent veteran suicide, we got to maximize those protective factors and minimize the risk factors. And that has to be at the individual, interpersonal, community, and the societal levels. Risk factors are those characteristics that are associated with the increased likelihood of suicidal behaviors. And so those things could be, you know, transition points, which is it could possibly be the veteran recently discharging from the military and trying to reacclimate into civilian life. That is a major transition for a lot of veterans because they have been so used to structure on a day-to-day basis, and the way of life for them is very regimented. It is very difficult for them to kind of reacclimate into civilian life. And we often hear things like, you know, they don't know what to do. They don't have any kind of sense of purpose and they're missing that lack of structure. It's like, what do I do next? Everything was kind of very systematic when they were in the military and very routine. And then now they come out and they have all this time, and they don't really know what to do. And it's very difficult for them to transition back into that. Other major life things can also increase the potential risk of suicide. That could be, you know, divorce or discord in your relationship. That could also be a lot of problems with employment. Either you lost your job or they possibly can't find a job. Or, you know, we see veterans who have recently retired, or financial issues, legal issues, major medical issues, or any kind of disability. Those all play an important role into increasing risk factors that are associated with suicidal risk. The death of a loved one, excuse me, including, you know, history of being a survivor of suicide, transition into a nursing home or a loss of independence is also one of those things that are risk factors for veterans of suicide. So, and also another one that's not on there is a history of trauma. Again, veterans could have faced trauma while they were in the military, or again, a lot of veterans have had trauma prior to being in the military or since coming out of the military. So that is also a risk factor. Next slide. So we've also found that there are some significant risks associated with older adults. Males over the age of 75 have the highest rate of suicide compared to other segments of the population. So even though that rate that we saw earlier between ages 18 to 34 was significantly higher, male veterans over the 75 and older are at a more higher rate of suicide. What we see is some of the greatest increase in suicide rates is in males who are over 50, and they're more likely to engage in planful and determined self-directed violence. So they're going to do that, you know, researching ways to die on the internet. We see that a lot. I respond to, part of my job is to respond to calls that come in from the Veterans Crisis Line. And a lot of things that I hear is that they researched on the internet ways of, you know, how many pills do I take? Or, you know, where can I actually shoot myself where I know that I'm going to actually kill myself. So we found that it is more planful and it's more determined at that age. They're less ambivalent or impulsive, which means they have high lethality methods. Suicidal behavior is also more lethal later in life due to fragility, because you are older and you are less agile. So it's more common and it's more likely. Significantly less contact with mental health services and less likely to report suicidal ideation. So about 70% of males and 50% of females over the age of 65, they didn't have a known mental illness, or they didn't talk about the known mental illness. They didn't seek any kind of help for it. I often hear things like, what's the point? Who cares at this point? They're at a later age in life. They feel like it might be burdensome to other people, so they don't really seek out mental health services. Next slide. So comorbidity and suicidal risk there's an association. So there's estimated relative risk of suicide, which increases with the number of illnesses. Higher levels of functional impairment and disabilities. So those who have physical ailments and possibly mental health diagnoses are at a more elevated risk of a suicide. And also we found that veterans who are older often have less social supports. They're not as active. They're more likely to live alone. They're more likely to have fewer social activities or hobbies. There are and I'm not suggesting that, a lot of our older population does not engage in other supports or they have hobbies or activities. But what we often find is that they are less engaged in activities. They are less engaged with their family members. A lot of times they may be experiencing bereavement of their own. Either they lost a partner, people who are within their age range are starting to die, people who they're more close to. And so they become more isolated, and it decreases their chance for life-saving intervention because they don't have those social supports. So they may be less involved with their children or just their family as a whole. We often hear, that we didn't know what was going on. We thought that they were doing okay, or we tried to reach out and they wouldn't let us in. They wouldn't answer our phone calls. They wouldn't respond. Those are kind of some of the things that are more common with our older adults. So these are some of the warning signs, and some of these are going to be obviously a little bit more obvious than others, but obviously if they're threatening or planning to hurt or kill themselves, that's a clear warning sign. If they're seeking access to lethal means, and it doesn't necessarily have to be a firearm. Again, are they, purchasing more over-the-counter medications than they should? Do they have access to more medications? We know in our older population, often they do. They have access to more medications than maybe someone between the ages of 18 and 34 because of those other health factors that they have going on. But are they looking up ways? Are they going to the drugstore or, more frequently? Those are kind of some of the things that are warning signs. Talking about it or writing about death and dying or suicide. Are they more preoccupied? Is that more a part of the general conversation? A lot of times we hear, I just feel like I would just be better off if I weren't here. Sometimes I feel like it would be okay if I just didn't wake up tomorrow. Those are some of the common things that we see, some of those warning signs, and those are things that you need to pay closer attention to. One of the more obvious ones is increased substance use or abuse of substances. If they have a history of drug and alcohol use and they are starting to use more than what they typically would, those can be potential warning signs for suicide. Or if they recently start using substances, and this is a person who maybe never did before, those are some things to consider. If they, again, say that they have no reason for living, sense of purpose or loss of interest, that's in our younger vets and that's in our older vets. Like I said, people who are newly getting out of the military, oftentimes they feel like they don't have a sense of purpose. They don't know what to do, no direction. And then again, in our older population, they're starting to get older, they're starting to have more health concerns. And so they get a sense of, they kind of start to think, what's the point? And so they don't want to live anymore, or they don't want to live with this condition anymore. Anxiety, increased anxiety or increased agitation or being unable to sleep. Those are also warning signs. Expressing that they feel hopeless or worthless, helplessness or despair. Being withdrawn or isolated. Burdensomeness is a big one. I hear often, when I always ask our veterans, who's the support for you? Who can you reach out to? And a lot of times they say, I don't want to burden my family with this. Someone recently told me that they had a close friend, but they feel like they're always calling this close friend and kind of complaining about things. And so they don't want to burden them. So they kind of stopped calling them after a while because they just felt like, I don't want to start to bring them down because of what's going on with me. So some of those are warning signs. Feeling guilt and shame. And that could be related to anything: guilt about their mental illness, guilt about maybe not being as engaged with the family. Those are also warning signs. And then neglecting their personal welfare or their personal safety, taking care of themselves. Are they showering? Are they getting out of bed? Are they eating? Are they taking care of themselves on a day-to-day basis? And if you're finding that they're not, then those are things that could be considered warning signs. Next slide. And so these are some risk factors. Suicidal behaviors. Are they engaging in suicidal behaviors? Are they looking up ways to die? Are they expressing more thoughts on a regular basis that they're having thoughts about harming themselves? Are they doing things like cutting? Or in any other potentially harmful behaviors? Are they engaging in those? Obviously, a risk factor is going to be their psychiatric diagnosis. And doesn't mean that just because you have a psychiatric diagnosis that you're automatically going to be having thoughts about harming yourself or engaging in self-directed violence, but it is a factor. Physical illness, pain, or non-suicidal injury, those are also risk factors. We hear a lot that our veterans cannot manage the pain. A lot of our veterans suffer from chronic pain, and they have either been dealing with it for a very long time and have gotten to the point where they're just starting to feel hopeless and no longer want to deal with it, or this is some new pain or some new chronic illnesses that they just don't know how to manage. And so they just feel hopeless and they feel like they want to harm themselves. Again, we talked about earlier that history of trauma or being exposed. A lot of our veterans are exposed to other veterans who have completed suicide. And so it is not uncommon to know one or more people who have completed suicide when you are a veteran. Psychological features such as hopelessness or being impulsive, cognitive features, traumatic brain injury is very significant in the veteran population. We have a lot of veterans who suffer from a TBI and they are no longer able to function the way that they once were. And so that increases their risk of potentially wanting to harm themselves. Demographic features: where do they live? What is their community like? Who are they surrounded by? We have found that the suicide rates are a little bit higher in populations that are more rural, people who live in more rural areas, because they don't have as much access to other people. They don't have as much access to mental health services. And so we have seen that there is kind of a larger population depending on your demographic area. Lethal means access. What is their access? Do they have access to firearms? Do they have access, like I said before, to readily available access to an abundance of medications? Obviously, the risk is increased if they have access to a firearm, and then we want to take into consideration, is it loaded? What is their access to the ammunition? Can we have a conversation about either removing the gun from the home or separating the gun from the ammunition, separating the ammunition from the gun? Other risk factors include insomnia, poor or absent therapeutic relationships and lack of social support, substance use, and loss. That could be a loss of housing, a loss of their relationships, a loss of their functioning, and a loss of their freedom. And then obviously another risk factor would be their recent discharge from the emergency department or an inpatient hospitalization. Veterans who have recently discharged from the hospital have a little bit more increased rates of suicide than those who have not had a mental health hospitalization. Next slide. So these are some risks that are more specific to veterans. So again, exposure to extreme stress, whether that's related to their time in the military, whether that's related to recently being out of the military or related to family issues, they just seem to be more exposed to stress. Physical and sexual assault while in the service. And this is also a major one. Military sexual trauma is very common in the military and not limited to the female population. We have a lot of male veterans who have suffered physical assault or sexual assault during their time in the military. So that is a specific risk for suicide. Service-related injury. Were they hurt while they were in the military? Was it a significant injury? Something that has impacted their ability to function physically. Again, traumatic brain injury, PTSD, lower rank or recent demotion, Access to and familiarity with firearms. Obviously, we know that our veteran population knows how to handle firearms. And their times of transition are especially risky, which we talked about a little bit earlier. And then their LGBT status and their combat status. Were they involved in combat? And not necessarily were they actually involved in combat, or were they in a deployment area? Were they in an area where there was combat around them? So suicide is preventable. You don't have to necessarily be a professional to be able to help prevent suicide. So some of the protective factors include that help with preventing suicide is positive social supports. So again, that is, are they involved in mental health services? Are they engaged in mental health care, whether it be at the VA or whether it be in an outside agency? Do they have a social support as far as friends that they're close to or family? Or do they have any spiritual beliefs? We have chaplain services that we offer at the VA, and often all of our veterans who have been identified as high risk get an automatic referral to our chaplain, because a lot of veterans find that helpful. And so, do they have a sense of spirituality? And it doesn't matter what their beliefs are. We just want to make sure that they have some form of a spiritual connection. Do they have a sense of responsibility to their family? Do they have children that they take care of? Do they have family members that they take care of? That could be one of the reasons that veterans often tell us that they would not harm themselves, because I have to be here for my family. Again, do they have children in the home? Are they satisfied with their life? How satisfied are they with it? Do they feel like they have that sense of purpose? Reality testing ability, positive coping skills, positive problem solving skills. How do they manage those stressors? What do they do? What coping skills are they able to utilize? Do they have any kind of positive therapeutic relationships? How do they get along with their therapist that they're working with? I often hear that, I didn't make a positive connection. I didn't feel like they understood me. And so what I try to stress is, you have to tell your therapist what it is that you need from them. And instead of just discontinuing your sessions, don't just stop coming. Say, hey, this is what I need from you. I feel like maybe we didn't connect. I feel like maybe it's not a good fit. And then seek out another therapist if that's possible. Or again, you got to be really open about what it is that you need in therapy and what it is that you need in that relationship. Do they have a fear of death and of suicide? And are they future oriented? Do they have plans for the future? Whether it's in the short term or the long term? It could be, I'm looking forward to getting a promotion at my job, or I'm looking forward to a vacation that's coming up, or it could be, in the long term. But are they future oriented? Are they planning things for the future? And then are they willing to safety plan? Are they willing to identify support persons in their lives who can help them when they start to have more depressive thoughts, or when they start to have thoughts about suicide, when they start to become stressed about things and it becomes difficult for them to manage? Who can they identify? We help our veterans come up with a safety plan that they have access to. We work with them to develop the safety plan, but it's in their language. It's the people that they choose to identify. And it has an outline of where can I go? What places can I go to? What support systems can I rely on? What things can I do when I start to have these more intrusive thoughts about harming myself? And again, how can we reduce access to lethal means? Ideally, we would always love for our veterans, for anybody for that matter, if they have access to firearms, we always want the plan to be, hey, can we remove the firearm from the home? But that's not always possible. And we can't force that. We can't, say, hey, you got to remove this gun. And police removing the gun sometimes happen and sometimes does not. So what else can we do? How can we include that veteran in a plan to keep them safe? And again, that may look like they have a lockbox. They have gun locks. We have gun locks that we send out all the time. That they have somebody who maybe the box is locked and somebody has the code and the veteran doesn't, or somebody has the key and the veteran doesn't. So what kind of creative things can we come up with to reduce their access to lethal means, thereby reducing the potential for them to harm themselves? So at the VA, we have what's called our VA SAVE training. And we do it within the VA, and we also do it in the community. And essentially what it does is it teaches communities how to help veterans who are at risk for suicide. And the VA SAVE can help you to act and to act with care and compassion if you encounter a veteran who is in suicidal crisis. So what the acronym SAVE stands for is signs of suicidal thinking, ask the most important question of all, validate the veteran's experience, encourage treatment, and expedite getting help. So we want to learn to kind of recognize what the warning signs are, which we talked about a little bit earlier, that hopelessness, that anxiety, feeling like there's no reason to live, rage or anger, engaging in risky activities, increasing alcohol or drug use, or withdrawing from family members. And so the presence of any of these following signs requires immediate attention. So thinking about hurting or killing themselves, looking for ways to die, talking about death or dying more frequently, or just kind of engaging in self-destructive or risk-taking behavior, especially if it involves alcohol, drugs, or weapons. So A is the ask. You know, we want to ask, know how to ask the important question of all, which is obviously, are you thinking about killing yourself? There's no, I mean, it's best to be direct when you're asking the question, to ask that direct. So it kind of takes the autonomy out of it, the ambiguity out of it. You know for sure, if you're asking this question directly, there's a yes or there's a no. So things that you do want to ask. You do want to ask the question if you've identified those warning signs. So if you've identified that they're, you know, researching ways or talking more about it or looking things up on the internet or engaging in risky behaviors, you want to ask the question if you've identified those warning signs or those symptoms. You do want to ask the question in a natural way that flows with the conversation. You don't necessarily want to blurt out, are you thinking about killing yourself? But you do want to ask in a way that if they're telling you about all of these things, or you're starting to see some of these signs or symptoms, you can kind of segue it into the conversation. You don't want to ask the question as though you are looking for them to say no. So like I said, you want to be direct. Are you thinking about killing yourself? Have you had thoughts about killing yourself? But you don't want to do it in a way where you're asking, you're not thinking about killing yourself, are you? Because that right there gives the impression that you don't want to hear the answer. You don't want them to say yes. You want them to say no. So when you're formulating it that way, then you are automatically making them think that, you know, they really don't want me to tell them that this is what's going on with me. You don't want to wait. Don't wait to ask the question like when they're halfway out the door. Or when if you're in a phone conversation and you're kind of wrapping up the phone conversation, you don't want to wait until the end to say, oh, by the way, have you been having thoughts of killing yourself? You want to make sure that you're having that conversation as they start to identify some of these risk factors to you. You're starting to ask them this. And that way, you know, you don't want to be in a situation where you know, that you hang up with them or they leave the house or whatever environment that you're in, and you know they're gone, and you don't have a way to kind of reel them back in. Because at that point, it could potentially be too late. Next slide. Oh, thanks. The V stands for validate the veteran's experience. So you want to talk openly about suicide. You want to be willing to listen and allow the veteran to express his or her feelings. And I know that it can be a difficult subject matter. You know, obviously some of us are more professional and it's a little bit more natural, but you don't have to be a professional in mental health or a professional period to be able to have an open conversation with either a veteran or a loved one, a friend, about suicide. Recognize that the situation is serious. So if they are starting to tell you, you know, yes, I'm having thoughts about harming themselves, or, you know, they start to kind of give you ideas that become, you know, thoughts that are becoming more concerning about something that they say, recognize that it's serious. A lot of times we may tend to kind of blow things off because either one, we don't know how to respond if they do tell us that they're thinking about harming themselves, or maybe we just don't want to be put in that situation. But what you don't want to do is assume that they're not being honest or they're not being truthful when they tell you these things. You want to not pass judgment. So you want to steer clear of you know, placing your own kind of thoughts about suicide onto somebody else. You don't want to say things like, you know, God would be angry if you did that, or why would you want to do that? Or, you know, you don't want to judge people when they share this with you. And you want to reassure the veteran that help is available. And again, even if it's just something as simple as calling 911, you just want to let them know that help is available to them, and this is not something that they have to do. This, even if you don't have the means to be able to help them, somebody has the means to be able to assist them. The E is for encourage treatment and expedite getting help. So don't keep the veteran's suicide behavior a secret. If a veteran tells you, or anyone for that matter, tells you that they are having suicidal thoughts, they've identified a plan, they have intent to act upon it, you don't want to keep that to yourself. You want to be able to tell someone as soon as possible. Obviously, if you're in a professional setting, if you can, you kind of want to rope in your other coworkers, your immediate supervisor, whoever you can to be able to get you to be able to assist you. But you don't want to keep that to yourself. If it's a family member or a friend that tells you that, you don't want to keep that information to yourself. You don't want to leave the veteran alone. If they've identified that they are thinking about harming themselves, or they have identified several warning signs, you do not want to leave them by themselves. You want to, again, elicit help, and that could be by calling 911. It could be by calling the Veterans Crisis Line, but you don't want to leave them in a situation where they're by themselves. You want to try to get them to seek immediate help from their doctor or from the nearest hospital or emergency room. Again, so that would involve calling 911, reassuring them that help is available, or reaching out to the Veterans Crisis Line at 988 and by pressing 1, and they'll be directly contacted with someone on our Veterans Crisis Line. And then the 988 is the newer number that we have. The old number, the 1-800-273-8255 is still working, but 988 is what we're giving to our veterans now, and we have a whole push of information that we are sending out with the new number. And some of the things, next slide, yeah. Some of the things that you want to do when you are talking to a veteran or anybody at risk for suicide is you want to try your best to remain calm. And I know that that is much easier said than done. Oftentimes that's hard to do because you don't know what to do. You don't know how to respond. You're thinking, why did this person tell me this information? What do I do now? And all types of things start running through your head, which is totally normal. But you want to try your best to remain calm, because if you remain calm, then you can help the veteran to remain calm. And so, and you don't want to be in some, kind of a panic mode, and then that causes them to panic. So you want to do your best to kind of remain as calm as you can. You want to listen more than you speak, which means limit your questions. And let the veteran do most of the talking. So obviously you want to get the important information. If this is somebody who you're on the phone with and you're not face to face, you would want to know where they are. You would want to know, who is near them. Like if they're at home, is there somebody else in the home with you? You would want to know what their access is to lethal means. But once you've kind of gathered that information, you want the veteran to do most of the talking, because what you find is that sometimes if they're able to talk through this, then that kind of helps them to de-escalate. And that can be, that can make all the difference in them following through with the suicide attempt or kind of rethinking this. You want to be able to maintain eye contact, or if you're on the phone with them, make sure that you're staying, that they have your full attention. We live in a world of everything happens on our phones, and we're often swiping left and looking at various things on our phone, but you want to make sure that they have your 100% undivided attention, that you're looking at them, that you're listening actively to them. And you want to act with confidence. And again, not expecting you to be a professional. I understand that that's easier said than done, but you kind of want to act in a way that you feel confident helping them with whatever is going on. Another important one is you do not argue. It happens often when I am on the phone with the veteran from the Veterans Crisis Line that they are upset. And it's not necessarily because of anything that you did, but they're upset. They're upset with the VA because they feel like they're not getting what they need. They're upset with family. They're upset with job. Any number of reasons. But you don't want to be in a position where you're starting to argue with them, or you're starting to escalate because they're escalating. Again, that goes back to remaining calm. But you just don't want to get into an argument where you're going back and forth with them, because something that you say could potentially, lead to them disconnecting the call or walking out of your office. And then once that person is gone, we may not be able to get them back. So you want to use open body language. Be mindful of how you're sitting, where your hands are placed. You want to use supportive and encouraging comments. Things like, I know that must be difficult for you. I'm sorry that this is something that you're going through right now. You know, how can I be of assistance? What can we do to make a plan? You want to kind of have those, that supportive language when you're talking to them. You want to be honest, and let them know that there are no quick solutions, but there is help available. I am always very, very upfront when I tell veterans that unfortunately this may not be something that we can resolve today, but there is help available. And I always let them know that things are a process, whether that's your mental health journey, whether it's you're facing homelessness, you know, whether you're seeking a new job, things are a process. So there's not a quick fix, but we are going to be able to assist you. And so just reassuring that help is available to them. And again, ideally, if they're a veteran, we would want that help to be through the VA, but it doesn't have to. If they're not comfortable coming to the VA for whatever reason, whatever community resources that you can provide to them, I would strongly encourage that. And so there are some anchors of hope as it relates to suicide among the veteran population. So there has been a declining rate of suicide among veterans in recent Veterans Health Administration care for veterans who have a diagnosis of depression. Some evaluation of VA outpatient and mental health program indicates that after 3 months, veterans who initially reported having some sort of suicidal ideation were about 1.9 times more likely to report less severe suicidal ideation. So what we're finding is that the more engaged they are in care, the more appropriate services that they're integrated with, the less likely that they are to have those increased thoughts of suicide. Usually the suicidal thoughts become less severe. And it doesn't mean that they don't have them. We certainly have a lot of people who have chronic suicidal ideation, who always have it in the back of their mind, but maybe they're not planning on acting out on it. So reductions in suicidal ideation were also documented for veterans who received VA acute inpatient mental health services. So for those who had to spend time on our inpatient unit, we found that there was a slight reduction in their suicidal ideation. So what I touched on it a little bit earlier is just one of the things that we see, one of the major things that we see is kind of the stigma surrounding mental health and how that impacts our veterans' willingness to engage in care or either seek care and engage in care. So how can we reduce it so that we can promote their wellness? So some of the stigma of mental health is often veterans who suffer from mental health, they don't actively seek help. And that could be for any number of reasons, but they often delay in seeking treatment. And it's also attributed to concerns about being treated differently, fear of losing their jobs or their livelihood. A lot of times veterans, you know, there's this automatic stigma for veterans that when they come out of the military, they're going to suffer from some sort of mental illness, whether it's PTSD, whether it's depression. But a lot of times it's often assumed that if you were in the military, you're going to have some sort of form of mental health. And then if you also think about the veteran population, a vast majority of our veterans are males. And we know that oftentimes males are a little bit more hesitant, a little more, less likely to seek treatment sometimes. And so stigma often comes from, you know, lack of understanding, or it comes from fear, you know, or inaccurate or misleading media also represents of mental illness contributing to both of those factors. So some things that we see in the media, ways that we're portrayed in movies, you know, sometimes on commercials, a lot of that plays a role into our overall thinking as it relates to mental illness. So some types of stigmas could be public stigma, which involves, you know, negative or discriminatory attitudes that others have about mental illness. I mean, and you know certain things that you've heard about mental illness. You know, they're crazy. You know, something's wrong with them. Oh, the war messed up their brain. You know, these are some of the negative things that we have about mental illness because we don't understand it. It could also be, it doesn't necessarily have to be public stigma. It's also self-stigma, which refers to those negative attitudes, including internalized shame that people with mental illness have about their own condition. We feel bad about it. We feel like, you know, why did this happen to me? We ignore it. We feel like, you know, some of the things that we are experiencing, maybe we don't feel like we're really experiencing, and we feel ashamed, and we don't want to talk to other people about that because of how we think that they're going to portray us, how they're going to view us, how they're going to relate to us. Are they going to treat me the same if they know that I have PTSD? Or if they know that I have schizophrenia or depression, you know, are they going to tiptoe around me, you know, and not know what to say or not know how to engage me or include me in things? So stigma not only directly affects the individuals with mental illness, but it also affects their loved ones who support them, often including their family members. Some of the harmful effects of stigma could be, you know, being reluctant to seek help or treatment and less likely to stay with that treatment. So it's kind of a twofold thing. You're already hesitant to get involved in any kind of mental health care. And then when you get involved, a lot of times they don't follow through, you know, because we don't want to, it's hard for us to manage. We don't know how to manage it, or because things are coming up that are difficult for us to deal with. And a lot of times you have to relive that trauma. And so a lot of times they don't want to deal with that. They don't want to stick with that. It's very difficult. Social isolation. A lack of understanding by family, friends, coworkers, or others, less opportunities for work, school, or social activities, or trouble finding housing, bullying or physical violence or harassment because someone who's suffering from mental illness and you know, harassing them or being physically aggressive towards them or verbally aggressive. Health insurance that doesn't adequately cover your mental illness treatment. Or the belief that you'll never succeed at certain challenges or that you can't improve your situation. So these are some ways that we can reduce stigma. First and foremost, it's important to educate yourself about mental illness. And, you know, the more educated that you are, the more you can educate other people, whether that pertains to mental illness within a family member, mental illness in our veteran population, or anybody that you work with. Kind of familiarize yourself. Learn about, you know, the signs and the symptoms of depression or PTSD or schizophrenia, you know, or drug and alcohol use. Become more familiar about what some of those symptoms are. Be aware, be cognizant of your attitude and your personal beliefs and your behavior. What kind of ideas do you have? What kind of thoughts, and how might that transfer over into someone that you're working with, whether it be a family member or whether it be a veteran? Choose your words carefully and be mindful of judgmental statements or disparaging remarks. Again, going back to those, you know, some of the obvious ones like, oh, you know, don't talk to them because they're crazy, or, you know, something's going on with them. You got to be mindful, and you never know who's suffering from mental illness. Sometimes there are people who we can tell it's more obvious, it's more pronounced, and we know that they're suffering from something. But a lot of times, most often, people are suffering in silence, and we don't know. So you don't know what kind of statements that you may be making, that you may be saying to someone who is directly impacted by mental illness, whether it's personally or whether it's someone in their family or direct circle. So you want to be mindful of things that you say and steer clear of making negative remarks as it pertains to mental illness. And you want to support people. You know, treat everybody with dignity and respect. That's just kind of the simple way of life. You know, people are going through things, and a lot of times we don't know how to deal with it, and that's okay. But make sure that you're treating people respectfully, and you're not, you know, being disrespectful or being degrading. And try to offer support and encouragement. And again, if that's not through you, maybe it's, you know, somebody that you have access to, somebody that you can get them connected to in the community. The most important thing that you can do is be there for them. For our veterans who are suffering from mental illness, from people in your family or your direct circle who are suffering from mental illness. I also wanted to touch a little bit on the importance of taking care of yourself. That's one of the other things that you want to do. I know a lot of times that when you are dealing with families who have mental health, or a veteran who has mental health, you know, nobody is to blame for it. There's no one particular thing. It's not your fault that someone is suffering from mental illness. So you want to be able to kind of understand their symptoms and understand that their symptoms, they may come and they may go. Some days may be better than other days. Some days may be worse off than other days, but you want to be able to understand the severity of it, and that it may vary. And then you have to kind of determine, what is your level of support going to be? You know, your support may be different based on your understanding of the mental illness, based on what you're able to offer because of things that are going on in your own life. So, you know, different levels of support may be required at different times for you and for your loved one. So you kind of want to make sure that you're taking care of yourself. You want to develop a sense of balance between your own needs and the needs of the veteran and the person that that you're taking care of. Decide what level of support is important to you. What can you provide to that person? And another thing that you can do is consider a support group. Rely on other support from your family and from your friends. So just as it's important to take care of our veterans, it's also important to take care of yourself, you know, so that you're not getting in a point where things are starting to happen with you and you don't have control over it or you don't know how to deal with it. And so I just want to touch on a little bit about our public health approach to suicide prevention. And so the VA's public health strategy, it combines partnerships with the community, and it's developed clinically based strategies for prevention of veteran suicide. So again, we want to make sure that we're reaching out to the communities. We want to make sure that it's clinically based, and that we kind of have a full public health model of how we can help prevent suicide. Because again, it's not one thing, it's all encompassing. So we want to make sure that we are reaching out to the community and doing our SAVE trainings, or identifying veterans who are at need, because a lot of times our veterans are not connected with the VA and you guys have more access to them than what maybe we have. So surrounding them with resources and making sure that they have the services that they need. Some other prevention strategies kind of in the short term that we are addressing here at the VA is lethal means safety. Again, what can we do to secure those firearms? What can we do to secure medications and other items that could potentially help save a life? And again, definitely firearms is the most common method, but there are also many other methods. So we want to make sure that we're not overlooking those, we're not negating those. Caring for veterans in a specific medical population. Those could be those veterans who are in nursing homes, or hospice, or group homes, you know, making sure that they are also wrapped with the services that they need. And re-engaging people who were previously involved, or veterans who were previously involved in care and maybe they're no longer directly involved. We want to be directly reaching out to them to make sure that we are getting them linked with the services that they need. A lot of times our veterans don't know what services they qualify for, or they think that they have to be service connected, which means that they have to have some sort of medical condition that allows them to be able to have care at the VA, which is simply not true. So we want to just make sure that we're getting the message out there that at least call us so that we can see what it is that we can help you get linked with. And then we want to enhance our suicide prevention program, again, within the VA and outside of the VA. So, you know, the most important thing is just kind of joining us in our fight for suicide prevention. We want to be able to come together with multiple approaches so that we can prevent suicide. And that involves having meaningful connections with the VA, with the community, with outside hospitals, with other community agencies. And so these are just kind of some resources. They'll all be in the slides. You guys will have access to the slides. And these are some things that we use to be able to combat suicide. And the other slides are just going to be some helpful resources. Again, the Veterans Crisis Line is still active. They can still dial the 1-800 number, but we do have a new number, which is 988, and they will still press 1. It'll direct you directly to the Veterans Crisis Line. It's veteran specific. They will not be placed on hold. They will talk to somebody immediately. And the good thing is that, you know, a lot of times they don't feel comfortable talking. So they can reach out to the Veterans Crisis Line by chat, by text. So they can do all of that they can have access through the Veterans Crisis Line through all of those means. A lot of people don't feel comfortable talking, even though we're talking to somebody that we don't know. But again, we live in a world where we're tech. So everything is, I know for me personally, I'd rather send a text than talk on the phone. I know that's crazy, but I would. So we encourage that for them to get in contact with us any way that they can. And so again, the Veterans Crisis Line doesn't necessarily have to be just for veterans. It is also for family members. We get a lot of calls from family members who are concerned about their veterans. So we want them to reach out to us. We get a lot of calls from friends who are concerned. So it's not just exclusive to people who are veterans to call the crisis line. So if you know somebody who's a veteran, if you know a family member who has if you know a friend who has a veteran in their family, they can always reach out to the Veterans Crisis Line. And again, another thing that I want to stress is they don't have to be actively thinking about suicide to reach out to the Veterans Crisis Line. They may not be suicidal at all. It is just a level of support. A lot of times veterans don't feel comfortable talking to other people, or they don't feel comfortable talking to people that they know. And so they feel it's okay for them to reach out. I tell them all the time, it's not just a platform for people who are thinking about harming themselves. It's just that added layer of support. It's the middle of the night. You can't sleep. You're stressed, you're anxious, you need somebody to talk to or chat with. That's the reason for you to reach out to us. We're never going to turn anybody away. We're never going to terminate a phone call. We're never going to say, oh no, that's not appropriate for you to call for this reason. We're always going to talk to you. And we get a number of people who call. We get people who call for, things like they're worried about their financial situation, or they have a guardian and they're not getting their needs met. All of these are reasons that they can call, and we'll filter those. But most often, typically all of the calls wind up with the suicide prevention consult, whether they indicated it or not. As long as they're open to it, then we're always going to reach back out to make sure that they have the services that they need. Making the Connection is an online resource featuring hundreds of veterans who tell their stories about overcoming their mental health challenges. This is a really, really, really good website. Just, it's on YouTube, and you can just check it out and just listen to people tell their stories. And it could be a support. It could be information that you pass off to somebody else. I'm seeing some questions, Matt. So I will take them at the end. I'm almost done, okay? Coaching into Care. It's a program for families. This is another really good program. It's a program for family and loved ones of veterans, helping them to encourage the veterans to seek help. A lot of times we know that they won't seek help. What do we say to them? How do we get them, to push them towards getting involved into care? Coaching into Care is a really, really good resource. If you call the number, they can give you some really good information and working out how we can get our veterans into care. And again, it doesn't always have to be at the VA. If there's some place that they feel more comfortable, my goal is just to make sure that they're getting the mental health services that they need. And then Together We Can is a VA recently released a suicide prevention informational series for veterans, their families, and their caregivers about common suicide risk and protective factors. So some of those things that we talked about earlier, you would see in this if you go to this website. And so families and caregivers can learn about available resources and those practical steps that they can take to be there for a veteran in their lives. And again, I'm not expecting everybody to be a professional. I'm not expecting everybody to have the right answer. That's okay. We just want to make sure that you are ensuring that you're responding, quickly, and that you're ensuring the veteran that help is available to them and trying your best to get them to the help that they need. And this is our outreach toolkit. So it includes facts and this about suicide, as well as some information about how to establish a suicide prevention council, talking to vets about their military service, assessing suicidal risk, developing a plan, helping veterans feel more connected, and joining public and private partnerships. And then this one is our community provider toolkit, which is a great resource for people who work outside the VA. And you just are looking for some online training, some tips about how to screen clients for military service, and military culture training. Next slide. And this is our social media safety toolkit. Again, talking about the national strategy for preventing suicide. And it's a comprehensive and community-based suicide prevention strategy. So again, our hashtag is be there in whatever way that you can. Even if it's just reaching out, calling 911, if it's reaching out, calling 211 to find out what services are available. But the toolkit includes kind of best practices, some resources, and some sample responses. How can you respond to somebody who is expressing suicidal thoughts? This one is our lethal means safety toolkit, and this is going to be about gun safety, and talking about safe storage of firearms, and also how can we safety plan. You know, we respect the important role firearms play in many of our veterans' lives, and we're dedicated to working with the collaboration with veterans' values and priorities. So this will just kind of help you come up with some creative ways to ensure that our firearms are safely stored. Right, so I thank you guys. Sorry for some of the glitches that happened today, but thank you so much. Thank you for the role that you play in supporting suicide prevention, and thank you for your attention today. My email is included in there. You can always reach out to me. Like I said, my job is the suicide prevention coordinator, and so I work with veterans who have been identified as high risk, but we also do a lot of outreach stuff in the community. Reach out to me if you have questions. We also have a lot of material that we can give out if you need it. We have veteran crisis line cards that we could give you. I have access to gun locks that we could provide for you if you need them for somebody. Just reach out to me and we got a lot of stuff. We call it swag material, but we got lots and lots of it. So whatever you need, just reach out to me and I will make sure that we send it to you.
Thank you so much, Demetria. That was a very comprehensive and thorough presentation, very informative. So I would like to offer the space up now for anyone to ask questions. I do see, I did put in the chat the link for the evaluation for today's presentation. So if everyone could be so kind as to click that link and complete that survey for us, we would really appreciate that. I do see we have one question in here asking if there are any support groups that you can recommend, Demetria, for family members of veterans who or other loved ones who are veterans who are living with mental health conditions.
What I would suggest is contacting Coaching into Care, because they will walk you through that, provide you with resources for that. They are very, very helpful in that regard. I've heard very positive things about them. I know people who have reached out to them, and it's a really, really helpful tool. So I don't have any specific support groups that I know of. We use NAMI a lot because regardless if it's a veteran or if it's a family member suffering from mental illness, NAMI is an excellent, excellent support tool. I would say reach out to Coaching into Care, because they can guide you with resources that are going to be in your area.
Yeah, definitely. You know, you can always attend a NAMI support group. We do have many family-focused support groups, some of which have special focuses. Some are faith-based. Some have a particular focus, such as spousal support groups, or a dual diagnosis support group for families of individuals with co-occurring mental health conditions and substance use issues. So you can always find more information about our current support groups with NAMI at namigreatercleveland.org. Any other questions before we end? I just dropped the link to the survey in there once more. Demetria, do you know if there's a specific number people call for Coaching to Care, or do they go to their website?
The number is 888. I don't know if you put this in the chat.
I'll put it in the chat. Yeah.
Okay. 888-823-7458.
I just put it in the chat. Well, if we have no other questions, we can end it here. I will ensure that the slides are shared with everyone later today. There were some great resources there, especially at the end. So I will send those along this afternoon, as well as the link to the survey, and please do complete that for us. Thank you so much for joining us, and I hope everyone has a great day. And thanks for sticking with us through the technical difficulties. Have a wonderful week, everyone.
Thank you. Have a good afternoon. Thanks, Matt.
Thank you.